All right, codebreakers, welcome. You're stepping into the clockwork of the human heart, an intricate machine of gears and electricity. That line on the screen, the ECG, that's not just data. It's a language. It's the heart's secret code. And in this explainer, we're going to hand you the master key to decipher it all, especially for those big exams coming up. So take a look at this strip. Right now, it might just look like a bunch of random squiggles, right? But I promise you, by the time we're done here, you won't just see lines. You'll be able to read this story, a story of depolarization, repolarization, and the very rhythm of life itself. You know, to read any language, you have to start with the alphabet. Well, this is it. Every single heartbeat writes a sentence, and these are its letters. That first little bump, the P wave, that's your atria giving a good squeeze. We call that atrial depolarization. Then the big one, that massive spike in the middle, the QRS complex. That's the powerhouse ventricles contracting. And that last bump, the T wave, that's just the ventricles resetting, getting ready for the next beat. That's the core of the code, right there. Now, you don't crack a code by just guessing. No way. You need a systematic approach. This isn't about trying to memorize 100 different rhythm strips. It's about having one single powerful tool that works on every single one of them. This is your decoder key. And here it is, your secret weapon, the 8-step method. We are going to walk through this systematically every single time. First, rhythm and rate. Is it regular or is it all over the place? How fast is it going? Then we zoom in on the waves. Is there a P wave for every QRS? Are those PR and QRS intervals looking normal? This process, this checklist, turns chaos into clarity. It's the absolute foundation for crushing your exams. All right, let's put this key to the test. We'll start with the heart's baseline, the perfectly steady, normal rhythm. And then we'll see what happens when the gears inside start running a little too slow or way too fast. So, check this out. This is beautiful. A perfect normal sinus rhythm. Let's run it through our decoder key. Is the rhythm regular? Yep, the space between each big spike is pretty much identical. Rate looks to be between 60 and 100. Perfect. Is there a P wave before every single QRS? You bet. And are the intervals, the PR and the QRS, normal? Yes, they are. This right here is the rhythm of a healthy, happy heart. Okay, but what happens if the heart's natural pacemaker, the SA node, just decides to, take a little nap? You get this, sinus bradycardia. Now, the sinus part is good. It tells us the signal is starting in the right place. But brady, well, that just means slow. Notice here that everything looks perfect, except for one thing. The rate is crawling along below 60. The P waves are there, the intervals are fine, the rhythm is totally regular. The only problem is the speed. Now, sometimes you see this in athletes, but clinically you need to be thinking about other causes like vagal stimulation, maybe an inferior wall MI, or the effect of certain medications. So let's flip it. What if that pacemaker is now firing on all cylinders? This is sinus tachycardia. Again, coming from the correct sinus node, but tachy means fast. The heart is absolutely racing. Okay, exam alert. This is a huge triage point. Sinus tachycardia isn't usually a rhythm you treat directly. It's a symptom. It's a clue. Your first job is to figure out why it's happening. Is the patient in pain? Do they have a fever? Are they not getting enough oxygen? And here's the high-yield fact that so many people miss. If you see tachycardia that just won't go away after a heart attack, that is a massive red flag. It could be a warning sign of impending heart failure or even cardiogenic shock. Okay, we've seen what happens when the main pacemaker gets out of whack. But now, what happens when rogue electrical signals start firing from other places in the atria? Well, things get chaotic, and they get dangerous. This is one of the most common arrhythmias you will ever see, atrial fibrillation, or AFib. Instead of one coordinated squeeze, the atria are just quivering. It's electrical chaos, and that creates a completely unpredictable and irregular rhythm. Just take a look at this strip. Where are the P waves? They're gone. That baseline isn't flat. It's just this chaotic fibrillatory wave. And look at the space between the big QRS spikes. They're all over the place. That is the classic sign of AFib, an irregularly irregular rhythm. Absolutely no pattern to it. So what's the big deal with AFib? The number one danger is stroke. See, when the atria just quiver instead of contracting, blood can pool and form clots. Those clots can then travel right up to the brain. So our treatment has two main goals. First, slow that heart rate down with things like beta blockers or calcium channel blockers. And second, prevent a stroke with anticoagulants. And here's a classic exam question for you. What's a common cause of these atrial tachyarrhythmias? Digoxin toxicity. Don't forget that link. All right, we're now descending into the most dangerous territory. When the electrical chaos starts in the ventricles, your cardiac output can drop to zero in just a matter of seconds. These are the rhythms that kill. Ventricular tachycardia, VTach. This is when the ventricles just start firing off on their own, super fast. They're beating so quickly they don't even have time to fill with blood. This isn't just unstable, this is a life-threatening emergency. This is one of the most dramatic, frankly terrifying strips you'll ever see. Look at those wide, bizarre QRS complexes. They look like tombstones. There are no P waves, and the rate is just screaming along, often over 150 beats per minute. This is the heart's mayday call. Okay, listen up. This is probably the most important slide here. You see VTach on the monitor. What is your first action? It is not to call a code. It's not to grab a drug. It is to check if your patient has a pulse. That one single assessment splits your entire treatment path in two. If there's a pulse and they're stable, you have a little time for meds like amiodarone. But if they are pulseless, that is cardiac arrest. You start CPR and you defibrillate immediately. And this slide right here says it all. On the left, you have an organized, efficient system that gives you good cardiac output. On the right, you have pure electrical chaos that gives you no cardiac output. This visual contrast is exactly why you have to recognize this in a split second. Now, VTach can quickly fall apart into ventricular fibrillation, just a chaotic quivering of the ventricles. That's always pulseless and it needs immediate defibrillation. Or it can lead to asystole, a flatline. And remember, you cannot shock a flatline. For asystole, the only hope is high-quality CPR and drugs like epinephrine. Okay, so we've identified the bad codes, but how do we rewrite them? Well, we use pharmacology. Understanding how these anti-arrhythmic drugs change the ECG isn't just for pharmacists. It is absolutely essential for safe nursing practice and, of course, for your exams. This table is pure gold for studying. Seriously, each class of these drugs leaves a distinct fingerprint on the ECG. Class I sodium channel blockers, they widen out the QRS. Class 2 beta blockers, they just slow the whole thing down. Class 3 potassium channel blockers, like amiodarone, they prolong the QT interval. And Class 4 calcium channel blockers, they slow the signal down and prolong that PR interval. You have to know this table. And this is why we're here. This isn't just academic. It's not just for a test. Your ability to look at a screen, recognize a lethal rhythm, and act decisively within seconds, that's the skill that brings people back from the brink. It directly saves lives. So let's end with a final challenge. You're on the unit. An alarm blares. You look up and you see this rhythm. It's wide, it's bizarre, it's fast. Your patient is slumped over. Based on everything we just covered, what is your first, single, most important action? The clock is ticking. You are the codebreaker. What do you do?